Okay, we've got it. It says it's being recorded, so maybe we can take off now. Okay, I'm Miss Harrell. I'm in Alexandria, and we will be covering GU today, and GI today, and GU on Thursday. So, do I have any questions coming from Shreveport? Do you have any trouble with anything?
Oh, I'm having a lot of trouble. So I'm over here just trying to navigate this internet situation for the first time. How do I mute it?
Okie doke. Well, we're going to start out with our ticket to class, I think, and then we'll go into. So, are y'all seeing the ticket to class now?
Yes, sir. Yep.
Okay.
It's at the Bible book.
All right. What chapter are we working out of today?
24 and 25.
Right. Good deal. Somebody can pass this around for me if you don't mind in Alexandria. Okay. Basically, we had a ticket to class, and hopefully, it kind of parallels chapter 5 that Malik Abedel. So if you want to really go even deeper into it and see how you can apply the CJ Sim model, that chapter 5 has two boxes, and you might want to look at those. It's 471 and 475. It actually takes Malachi, who's 5, a little bit older child, but has the gastroenteritis, and you can actually see how you can learn through the CJM model as well as a good SBAR. So just FYI, you might want to do that. All right, we're looking at Harper, and this one's a 5-month-old female, and she came into the physician's office for diarrhea and vomiting over the past 2 days. So again here, picking out some cues, right? Remember the CJ Sim model? The first step is pick out cues. So what's the first 2 cues that you have picked out? Nausea and vomiting for 2 days. And her age is important because the younger you are, you dehydrate much quicker. Her mother reports she's been less active, so there's some neuro events coming into play. And she's a little bit on the sleepy side. She's unable to keep any feedings down today. She has had 4 loose watery stools, good description, right? Emesis time 3. Only other thing I would want to know, when was the last episode of emesis and diarrhea, and documented as far as time as well. She's not up. Here's another important factor. She hadn't had a wet diaper since yesterday. So what comes to your mind? Now we have her getting closer to being in the hospital. So what do we worry about when a child has not had a wet diaper in more than 6 to 8 hours? I'm sorry, severe dehydration. Good job. And that's exactly what we will find in a few minutes. Okay, she weighs this, and she weighed this. So there's a pound of weight loss. So that puts her in another higher risk. Those are all cues. So Harper is going to be a direct admit to the pediatric unit. A little bit about her social and her functional. Her mom's 21. She's single. I think she's a nursing student, and she lives with her parents. And she was a healthy baby, 6'10" at birth, and really had no current problems. She's on formula, and there was no complications. So past medical history looks really good, right? So we just have to get a hold of this gastroenteritis and take care of it. What data from the histories is important and relevant? So the relevant data is just what we all picked up, and those are your cues when you're looking at the CJ Sim model. And then the data from the social history is listed there, and we picked that right out. Some of the significance with the present problem is everything that we picked up, but we didn't mention UTI because we haven't seen their labs yet. So that's another thing that we didn't talk about, but we'll probably see it shortly. The data from the clinical significance, basically, she's probably so busy with her nursing that her nursing program that she probably isn't really involved with the child as far as childcare. Maybe her parents help a lot. The younger the mother, they just need a lot of encouragement. Some of them have a lot on their plate. So I always ask, is there any type of parenting skills that you need, or how to bathe the baby, how to take care of the baby, and we can get that for them. We will definitely be watching for bonding. I don't know if you've noticed in the clinical setting, some of the patients you'll have will have a real good bond with their parent, and then some it's real distant. So always talk about it with your instructor, and then y'all can move forward. When you're taking your NCLEX, you'll be asked to highlight data, and that counts as a test question. So we can't set it up like that right now to be able to give you that. But all the things that you just picked out is what I would be highlighting for the cues. This is the presenting vital signs. And what do you see there? Which ones are abnormal?
Sure.
All right. And what else?
Pressure's low.
Okay. Everything else is okay for her age. We're going to do a very quick assessment. And by doing this, we can note that she's irritable and is a little bit on the sleepy side. She cries but has no tears. So that goes along with what? Severe dehydration. Breath sounds are clear. So it's not respiratory. Look at her skin. So she's shutting down centrally, right? We have central circulation to be worried about. She's pale and cool. She doesn't maintain eye contact. Her bowel sounds are very active. And she had, here's some cloudy urine. So there's your first indication that she probably has a UTI as well. Then we move on to following our orders. Also, we note that her anterior fontanelle is depressed. She has dry tongue and no saliva. And her skin is tending over her abdomen. So we definitely have picked up that these notes that we wrote in, and now we're thinking of everything on board that could possibly be going on, GI as well as UTI and dehydration. In this chart, you had to just go through and put what you were finding in that presentation. Hopefully this column had the most of your things that you presented. What was her mental? Lethargic. So that would be listed here. What was her heart rate? A little bit on the tachycardic. Tears, what would you put here? Absent. Her tongue was parched. Her skin folds were greater than 2 seconds. Recall. And her cap refill was prolonged. Her extremities were mottled, and her urine output was minimal to none. Another thing, anytime you're doing an admission, we always want to make note if we have orders for potassium and a child has no urinary output, are you going to hang that bag or are you going to hold it? You're going to hold it until the child voids. And then you will go back and pick up the original order based on checking the potassium as well. And that is critical. I mean, if you don't learn anything today, I hope you'll take that back to your clinical setting. And what I see in the clinical, a lot of times we forget to hang the ordered bag. We held off the order bag. We're good on that because they come in the middle of the night and we'll be hanging a plane. But when you come on that day shift, start checking into that and get that bag ordered. It has to be mixed by pharmacy. So what is the primary problem with our little girl, Harper?
Severe dehydration and UTI.
All right, severe dehydration and UTI. What is the underlying cause of the concern? Basically the diarrhea, right? And the vomiting is what led up to this. And we know that loss of water is occurring and sodium from the extracellular. What is the nursing priority?
Dehydrate.
Okay, we're going to worry about hydrating this. We're going to monitor her cardiac output as well, because she's kind of headed toward trouble. Skin integrity as well, because with diarrhea, you want to put a skin barrier on their butt, because that acid in that stool will create a fiery red butt that hurts. So be proactive and thinking ahead when a child comes in with that. Get you some skin barrier. What interventions are you going to do with this child? A good assessment, right? And good vital signs. Okay. We're going to listen to our abdomen. We have a habit of not listening to abdomens for some reason, but we need to. What do you think her bowel sounds will sound like? Hyper or hypo? Hyper. Good job. We might want to put her on her right side after she feeds. She's going to have an IV for sure. We're going to continue to offer oral rehydration. She's probably going to be on clear liquids or Pedialyte. And how important is it that we get a daily weight and INO on her? Very, and we want to keep up with it hourly or every 2 hours on that intake and output. Don't wait till the end of your shift to report that the child still has not had any urine output, or they're not taking anything in. So you assess that and go with it and note, is it getting better or getting worse, or what's going on? How important is it we change her diaper frequently? Very, yeah. What body systems will you thoroughly assess on this child?
GI, GU, cardiovascular, neuro, integumentary.
Very good. And what's the worst possible complication that you think could happen to Harper? Yeah, septic shock. Yeah. Okay. And then what nursing assessment are you going to do? You begin if the complication does develop. Neuro checks frequently and vital signs frequently. The next is our medical management that comes into play, and here are the orders. I kind of put them in some type of order for you. A lot of these we do at the same time, but it says that she is going to be on enteric precautions. Is there a question? No, I'm just getting a noise background, I guess. But anyway, there's her labs, a CBC and a BMP and a urinalysis and CNS, stool culture for rotavirus, daily weight, IV. It's an NS bag with 20 meals. No, a plain bag at 20 meals per kilogram bolus over an hour, and then a maintenance at 2 milligram per kilogram per hour. So we've got our IV order. We'll be starting IV and collecting our blood and sending it off, and then hooking up our bolus. NPO, and she can have Pedialyte as tolerated. What's the Tylenol for? Fever. And then what's the Bactrim for? This is generic for Bactrim. What's it for?
Bacteria.
Okay, it's going to treat the UTI. Make sure that you have double checked to make sure that the urine and the culture has been done before you start the antibiotic, of course. All right, number 9 says put it in some order of priority. I basically have it in an order of priority. You may have to change it up a little bit. We definitely need to cover that fever pretty timely. So next will show your calculation for whether the medicine that was ordered is safe, and what did you figure it out to be. Her weight went to what? Yeah, 6.42 kilogram, and her bolus rate is what? Okay, and then her maintenance rate is going to be what? Okay, good job. 12. Her weight was 6.42, bolus rate's 128, and her maintenance rate is going to be 12 or 12.8. These are the labs. Tell me what's abnormal about these labs. Is that sodium abnormal? Yes. It's a little on the high side. How about the potassium? Our potassium's 3.1, so it's a little bit low. Chloride, it's a little bit low. Ours is 92. Her bicarb's low. Her glucose, it's normal. Her BUN, what's it?
Very nice.
Okay, it's high. All right, and the rest of all these are elevated. So we definitely understand what we're seeing and what we have put our cues together and trying to make a plan together. So I see with her, just by looking at this, you see the infection. Do you see the dehydration? Yes. All right. What lab results are relevant? Well, the sodium, really, most everything we looked at, the sodium, the CO2, the creatinine, the WBC, the hematocrit, and our neutrophils. And then this gets into the urine. So we know that a normal specific gravity on urine is 1.005 to 1.030. So hers is reflective of dehydration. All right, what does the above finding indicate? Just the urine alone indicates she's got a UTI, right? Critical labs, the creatinine, what does it tell us? How well her kidneys are functioning, okay? And what's going to be basically our nursing priority at this time? Hydrating, tissue perfusion, and prevent further complications. All right, then this is after all the orders went in. 2 hours later, this is what we're seeing. And so, what are you concerned about now? What do you think's going on now with her? Sepsis, right? Can you see? Look what happened to her blood pressure. Look what happened to her temperature. Oh yeah, went down very fast. So lastly, we probably need to complete our SBAR. Hopefully you did, and got in touch with her physician. What kind of things, what was your recommendation when you did complete your SBAR? Skip on to your SBAR and tell me what your recommendations were. Yeah, you're supposed to answer. I can hear y'all whispering. What did you put on your recommendation?
Continue the IV fluids, monitor the vital signs every 15 minutes, recheck the labs, strict INOs, and educate the parent on rehydration.
All right, and they'll probably be wanting to do some more. I suggest repeating. I heard you say repeat the normal saline bolus, and probably get some more antibiotics on board, right? Because we know that Bactrim isn't going to take care of sepsis. What antibiotics do you think they'll be ordering on her? Probably some vancomycin, maybe even some Rocephin too. So, and the last thing it says, describe psychosocial issues and what you can do about that. You have any idea of what you can do about that?
Reassurance and education on hydration, feeding, and infection prevention.
Exactly. And also don't forget her psychosocial. If she needs some help, we need to be very caring around her. We don't need to be we need to pick up on how anxious she is and worried, and ensure the art of nursing, which involves caring. There may be some resources that she's not aware of. We could get with social and see if there's any other resources that we can tap into. Okay, from this, you could actually take the CJ-SIM model and you could map it out. So the first thing was recognize cues. I think y'all did a very good job on that. The second is to analyze the cues. I think you did a great job on that. You said dehydration, severe dehydration is in the second where we're analyzing. We got to decide which one of these we're going to work on first. And that's going to be that severe dehydration because it's fixable, right? Then the UTI, and that's the analyzing the cues. Then we want to prioritize our hypothesis, and we know that this child has three things. And what were they? Gastroenteritis, UTI, and severe dehydration. And then that's where you want to move quickly to decide which one you're going to, we're going to work on all of them because of her age. And we came up with our plan. As far as generating solutions, we're going to look at all those things that we talked about that we were worried about and see that things maybe will hopefully get better. And that includes reducing that fever, trend in labs, her vital signs, getting fluids on board, looking at her skin, and then watching those vital signs. Because what we saw is we fixed one thing, but then it kind of went into something else. Take action is what y'all actually did. And then before we did our SBAR, what was the evaluation of the outcome? Was she improving, declining, or unchanged? She was declining. And that's just the way your CJ-SIM question on your test will unfold. Y'all do it without even knowing you're doing it, right? So stay focused when you're looking at those CJ-SIM questions, and you will do fine. Read what it's asking. Okay, I'm very impressed. Y'all are more than ready for today's lecture, and hopefully you learned something from that. Right, this is where we're starting today. These are our objectives. Can you see them where you're at?
Yes.
Okay, good job. This is what we're going to cover today. I won't read them all for sake of time because we will talk about them at the moment. You can add number 8, which is gastroenteritis, which we've already lectured on. So add number 8 to that, and we're going to, you'll also be taking care of in the hospital setting, maybe some rotavirus or norovirus. Does that ring a bell? If you haven't, you'll see it shortly, and that will occur in kids that are under 2 years old. And where do you think the rotavirus or the norovirus comes from? Daycare, right? Daycare is probably our number one where we pick it up. Again, if you travel out of the country, you'll have a risk for it, and the immunocompromised child will be at risk for it as well. Urinary we'll cover on Thursday, so I'll pick back up with objectives then on what we're going to be covering. If you look at the A&P for the pediatric GI, you'll see that everything enters the mouth. We talked about that previously. The esophagus sphincter is not fully developed until age 1, so that explains why.
Regurgitation.
Yeah, so these kids are at risk for regurgitation just because of their anatomy. Look how tiny their stomach is. 30 to 90 meals at 1 week. So we can basically cause problems by overfeeding just as much as underfeeding. They start out with 1 ounce or 2 ounce, and then they maintain that for a while, and then they'll get more. So I always ask, how much is your baby taking, and how often is your baby feeding or nursing? The intestines are still not mature. They're deficit of some of the digestive enzymes. So boy, we bring them into a world with an underdeveloped GI system. When you're doing your assessment, these are some critical things to ask. Always what was in the history, but if we're talking about diarrhea or vomiting, you want to know more than, yes, my baby has that, or my child has that. You want to know how many stools in the last 12 hours, or if you want to say 8 hours, or 24 hours. Diarrhea, the same thing. You want to know the color, the frequency, and the consistency. The vomiting, is it clear? Is it full of undigested food? Is it bile? That would be bad sign, huh? The daily weights, the vital signs, intake and output. What does the skin look like we did with our ticket to class? And ask if they're having any type of respiratory distress, because if it's GERDs, then that can lead to a bigger problem, aspiration. So these are all the things that when you get a baby with GI gastro, you want to be looking and trending vital signs, trending labs. Okay. All right. What's the answer to this? You've got a 4-year-old with hypoactive bowel sounds. What did you choose?
Active.
Yeah, good job. Okay. That's exactly. So how critical is it that you let somebody know when the bowel sounds are very, very hypoactive or absent? Absent is something that needs to be tended to immediately, huh? I think in nursing in general, we could do a lot better on our abdominal assessments in all age groups. All right. Dehydration, I think we've covered it a good bit. We identified in your chapter, you have the columns that go into mild, moderate, and severe. So go back and take a little recall of that. We know that oral rehydration is usually with Pedialyte, and it's from mild to moderate. And then for severe, we're going to be doing IV admission as well as oral rehydration. So with a high focus like we did with Harper. Yeah, we were ready we figured she was going to go into something else. What's the medication that we use for thrush? Nystatin, swish and swallow. Have y'all seen that in the clinical setting, or have you basically where it's a suspension? It's ordered 4 times a day, and it's best following a feeding. Use a Q-tip applicator, and you wipe it in their mouth if they're if they're tiny, or if they're older, they can swish and swallow. So you wouldn't want to put it right before a feeding, because then all the formulas or the breast milk's going to wash it away. So maybe after a feed would be good. We're talking about structural abnormalities now with cleft lip and cleft palate. What's the difference? What's the difference?
We haven't even,
Just involves the palate, involves the lip.
Cleft lip versus cleft palate. We'll see some pictures shortly. It deals with a structural difference. Which one would be worse? Probably a palate, huh? Yeah. Omphaseal is where the internal organs eviscerate through a sac in the umbilical cord, and you have to do a dressing with saline soap gauze, and they have to get to surgery. We have to protect that sac and prevent hypothermia or infection if surgery is needed. If the intestines are outside the body, again, that's prompt surgical intervention. Hernias, we'll talk about a little bit. You can have diaphragmatic hernias, and they can cause some respiratory issues. And then you can have some anal rectal malformations where either there's no opening or it's a prolapse or a narrowing. And again, when the doctor does his physical in the nursery, all that should be detected then. Cleft lip, cleft palate. They're 2 distinct facial defects that can occur single or together. And if you want to look at the pictures in your book, this is where they basically came from. I'm on page 457 if you like to follow along with your book. Cleft palate, that's how will you detect it? The first sign is going to be formula coming out of the nose. So, and you can see the opening is in the palate, and then you can have cleft palate and cleft lip. You can have one side or both sides, but Both of them are surgically repaired. The lip is usually done first and the palate is done much later. So what are we going to get for these children? Because they're not going to have surgery right away. It's going to be a lot of education on how to feed the baby, or some special nipples that we use. And we'll talk about those in a little bit. Nursing considerations. You basically want to look at the whole family to see how they're reacting, and you want to be very supportive and non-judgmental. We dream of a perfect baby, and this case didn't work out, but we want to ensure them that everything will be surgically fixed and barely even leave any type of scar. We want the parents to talk about any of their concerns or fears. We want to encourage bonding, and then the speech therapist is going to be the one that's going to come in and teach all the special feeding techniques. There's also parental support groups that you could get involved in or share with them phone numbers or meeting times. You can see if I have a child with a cleft lip or a cleft palate, they're going to require this whole team of people caring for them. And can you understand why?
For speech and
Yep. It affects their hearing. It does all kind of things, but we can get it fixed real within that first year of life, and hopefully within the first few months on that lip. If you look at under the preoperative, we want to know how the degree of the cleft and their ability to suck. We want to encourage breastfeeding if at all possible, because the breast tissue actually fills the gap. So the baby's not getting a lot of air. We also, if they're not breastfeeding, we're going to use a wide base nipple and a special nipple that's particularly for cleft lip. And these devices are in your book. You also can squeeze the cheeks together during feeding, which also decreases that gap. And that is 459 is the feeding devices. Preoperative, cleft palate or both. Again, we have to assess the degree. We're going to look for respiratory issues during feeding, and because they aspirate. We'll want to feed the infant in an upright position, and we're going to burp frequently, underline burp frequently. And why do we need to do that? Because with all these extra openings, what is the child sucking? Air, right? Post-op care for either is going to be a standard post-op care. If it's cleft palate, you want to protect the palate operative site by keeping things like don't let the child put its hands in its mouth. Don't put suction catheters in there. No straws, no pacifiers, no spoons or syringes. If it's we're going to incorporate elbow restraints to keep them from putting their fingers. Again, know your restraint rules and document releasing them periodically according to your hospital. These kids will require analgesics, maybe a little sedative. A little Tylenol usually does fine. We don't want the child to be crying. Why? There's sutures up in their mouth, so when they're open their mouth and crying, they could disrupt that. We want to be closely observing for two things: airway obstruction and hemorrhage. Breastfeeding is okay with the surgeon. Special nipples and devices are encouraged until the sutures heal, and the child is not allowed to feed themselves. Cleft lip. It's a little bit easier. All we need to worry about is resuming our preoperative feeding techniques. You wouldn't want to be brushing teeth with cleft lip or cleft palate. Clean the lip from suture line outward, and they will recommend cleaning it with what? So a little saline, just normal saline is good, or a little water. And then put an antibiotic ointment as ordered. What type of restraint would you plan to see on a child that has cleft lip?
Elbows are no.
The no-nos are the little mittens that go on their hand, because remember, their hand wants to go all in their mouth. So elbows or no-nos, that's good. And it's basically elbow or little hand mitten. What it says put the infant in supine or sideline, and why is that? Because what will they do? They'll try to rub their face on the sheet because it itches. So, and then they could tear up what the physician surgeon did. To avoid contact, on a suture line from the linen is the answer. Common complications. We just mentioned earlier that they're going to have a team that's going to come in, and one of them is going to be someone that focuses on ear infections. Otitis media is a common one. We're going to have somebody available to prevent speech and language problems. And we see more of that with cleft lip, because as I'm talking now, my lips are constantly moving. So they will put a more focus with the speech. The speech therapist is your provider of information. Hopefully you'll see that individual on the unit and follow them. It doesn't matter if that, asked to follow them. You can just learn so much. They teach all kind of stuff. So it's not just how to make noise. It's how to feed and how to take care of stuff like what we're talking about. More common with cleft lip was that blank. The teeth may not come in normal, so you may have to see an orthodontist, and they will have some feeding difficulties. But again, that speech therapist and the nurse, if they're both very caring and supportive, this will be like easy. Meckel diverticulitis, it's the next, and it says it's the result of an incomplete fusion of the ophthalmos sedentary duct during the embryonic development. So this is something that occurs before they're ever born. It makes a fibrous band that connects the small intestine to the umbilicus. You have an outpooching of the lower intestine. So it's considered a congenital anomaly. Your critical takeaway is going to be the clinical manifestations, because anytime you change a child's diaper and you see blood, this might be one of the things that could be causing it. Is bleeding, is painless rectal bleeding. Anemia, of course, if you're bleeding, the child's blood work will show some anemia. This is on page 460. Severe colic abdomen pain in children could be associated with an intestinal obstruction. So anytime, that's the number one thing when you're looking and changing diapers. If you see blood, then that could be this. It's not real common, but we have to talk about it and be able to identify what makes it different from any of these others that we're talking about. The physical exam will show some distension, hypoactive bowel sound, maybe a mass, lots of guarding. We know that the treatment is a surgical resection. Okay.
The common clinical manifestations is just painless rectal bleeding, and what were the other two things?
Okay, that was anemia and severe colic abdominal pain.
Okay, thank you.
And that's on 460 if you like to follow.
Thank you.
Oh, you're welcome. The nursing care, if my child that I'm taking care of is anemic, what do you plan in your day? Trend the labs, maybe even have to give blood products, right? IV fluids, NPO, will be part of the care. Report an acute abdomen. And the post-op care is going to be basically related to preventing infection, getting the intestines to wake back up, all your typical post-op abdominal surgery. And we're going to do a lot of education on the last blank to relieve family of any type of anxiety. All right, so those were more of things that are more acute. Now we're going into a chronic GI disorder group, and these are going to be a little bit more involved. And then what you're going to do, this is where the notes that I posted for you that are column notes, if you'll go through and bring out differences and put it in column notes instead of multiple notes, you will just be able to breeze through your tests because they all have their characteristic symptoms, okay? Short bowel syndrome is on page 451, and we know that if you turn to that page, what kind of, they can't absorb their nutrients, and they're going to be lacking some vitamins. And do you know which vitamins they're going to be lacking?
Yeah, page 450.
It's 451, short bowel syndrome. I saw it somewhere. Maybe I don't have the right page. Let me see if I can find it again.
88. 488.
488. Okay, good. Let's go to 488 and see what kind. We always have to pull in some nutrition because we're a little deficit in our nutrition teaching, I think. Let's go to 488. All right, there it is, table 24A. If you look at it, it says that vitamin mineral deficiencies associated with it is A, B, D, E, K, iron, and zinc. So you might want to write that in. 489, exactly. All right. We know that, do you think these kids are going to be maybe facing some dehydration, and why? Because they have loose stools, right? If part of your bowel is not present and not absorbing, then you get into diarrhea and dehydration, electrolyte imbalance, and they are going to need what? TPN, right? And if you look down a little bit below this, it's going to tell you what medications that we will be using. All right. They may be even, this is one time that you might see a child on anti-diarrhea medicine. Normally, we don't give children anti-diarrhea medicine, but this child will require that. They will be on TPN for a while, and then they'll end up with enteral feedings, which is little G-tube feedings. All right, so what do you think about? What's your recall on short bowel? Pretty sick kid, right? And they're gonna need probably be in the hospital a little while too, huh? All right, the next one. Why did I put olives on this slide? It's an olive-shaped mass. Yeah, if you look down a little bit further, you'll see. So here's your good visual when you're doing your column notes. You might want to write that in the symptom column. I'm saying column, C-O-L-U-M-N, meaning it's got all these diseases that we talk about or conditions, and it has a column for symptoms and interventions. And it's easy to take all these notes and put it on 3 pages if you type it. That's what mine looks like. It occurs when the muscles surrounding the pylori hypertrophies and it obstructs gastric emptying. So it's one of the most commonly surgical disorders that we see in early infancy. So if this is obstructed, here it shows the pyloric stenosis right there. The major symptom is vomiting that is projectile and forceful, and it gets worse. You get a lot of esophageal irritation. The vomit can even become blood tinged. This mass is hard, it's palpable, and it's near the umbilicus. Possible peristaltic waves, you can actually see it moving if you have the baby in the supine position with the little shirt pulled up. The waves from the left upper quadrant to the right upper quadrant. And this baby's going to be irritable and hungry. So what do they need? They need a pyloromyotomy, Pylorotomyotomy, P-O-M-Y-O-T-O-M-Y. To actually cut that muscle and relieve that obstruction. The pre-op, they're going to need some IV fluids here, right? Before they go to surgery, we've got to correct IV fluids and electrolytes go in this blank. They'll have an NG tube that's going to help gastric decompress so they're not vomiting. Remember what kind of vomiting? So we have retained so far projectile vomiting, and what else? An olive shape. Yeah. So when we say pyloric stenosis, that should be what comes to your mind. And what's the fix? The baby's going to have surgery. Post-op, it's going to be routine post-op care, and they're going to start out with clear liquids first, and that's going to be probably some Pedialyte. Then they will get back on breast milk or formula as tolerated within 24 hours. A little bit of vomiting is okay, but it's not going to be what? No longer will it be projectile. Very good. Of course, they will have a little incision, so it's typical skin post-op. All right, the next one we're going to talk about is Hirschsprung's disease, also AKA known as megacolon. Okay. Do you see the picture of the megacolon here? Yes. What's in there? What's inside this big megacolon right here? Lots of gas and lots of feces. So that's why the end result is going to be a ribbon-like stool. So when you change a diaper and you see ribbon-like stool, does that bother you? Yeah, something's wrong, right? Besides, they're going to be crying a lot too because this hurts. Clinical manifestation, one of the cardinal signs would be a delayed passage or absence of meconium. You remember the meconium that you saw last semester? It should have been passed within 24 to 48 hours, but these children do not. So they kind of leave, if they even get to leave, with that as a cardinal sign. Something needs to be followed up on it. They're going to have abdominal pain. They're going to have an abdominal distension, vomiting, failure to thrive, and what will you hear? Signs of a bowel obstruction, so hypoactive bowel sounds. And they will definitely have chronic constipation, and you will see what type stool? A ribbon. It'll look just like a little pencil. Your last state board didn't say ribbon, but what's another word that your state board might give you? Here are the choices: formed, thin, bulky, or diarrhea stool.
Thin.
Thin. Okay, very good. Why didn't you grab diarrhea? Because it's not diarrhea, it's thin. Okay, very good. Treatment is surgery. They're going to have a little ostomy, and then they're going to get that little ostomy reversed after a few months, hopefully 3 to 4 months. Okay. They pre-op nursing care is going to be prepare them using developmentally appropriate terminology and technique. So depending on their age is how much we show them or tell them. The bowel prep, the IV fluids, and the antibiotics will be part of the pre-op. And we're going to have the ostomy nurse through wound care come by and show all the little ostomy bags and how to change that. And then it won't be as scary if they've seen it, and they'll participate in the care. The post-op is routine. We're going to really worry about our vital signs, but no rectal temps, and you can understand that. You don't want to perforate anything that don't need perforating. Nutrition, bowel sounds, and passing gas. So all that is going to be part of your nutritional assessment Hydration is going to keep the IV fluids going. Pain relief, they may be on a PCA pump, and then we can also encourage a good position, rocking, changing, music therapy, whatever the parents bring in, or we can get something and bring in. The PCA is more, it says a school ager will more so have a PCA pump. Monitor for signs of infection, and you remember colostomy alertness. What was that? If the stoma is red and beefy, is that a healthy one? But if it's black, that means it's necrotic. If it's real dry, there's a problem. So we just have to kind of take a peep, and when you're charting, make sure you chart every time you assess it multiple times during your shift, what that stoma looks like. Is it prolapsed? Is it flat to the abdomen? Is it moist, beefy, pink? Or, as well as what's coming out. And anytime the stoma is not that, you need to let the doctor, the physician know, the one that did the surgery. Provide education and relieve anxiety. And that's going to be just basically through teaching ostomy care, wound care. We're going to monitor for signs of infection and monitor for any signs of dehydration. So we're going to teach ostomy care. We're going to teach any type of wound care that may be necessary versus comparing different types of products there. Okay. Let the parents talk and verbalize any fears. The best person that can help us, all of us, is going to be the wound nurse. They're noted, and they bring in a whole suitcase of stuff for them to see and feel and touch. All right, so how many have we covered so far? Which one had the ribbon stools? Megacolon or Hirschsprung's, right? Okay, and which one had the olive mass and the projectile vomiting?
Pyloric stenosis.
Pyloric stenosis, okay. Which one had the bloody diaper and suffered with anemia? Diverticulum, okay, good. Which one am I forgetting that we've talked about, or have we? Oh, short bowel syndrome, okay. And then the other was cleft lip and cleft palate. But all of those, see how distinct? They're all different, right? You learn them one time, you talk about them, and you got them, okay? Put that visual picture in your brain, and you will do just fine. All right, next is going to be GER and GERD. Somebody tell me the difference between GER and GERDs. That's on page 283. What's the difference? Not 283. It's 284. What's the difference? One's just a little spitting up. Which one you gonna call a little spitting up? GERD. But if it stays and hangs around long enough, it's gonna end up being GERD. Okay. And there's medicine. And why we don't get it on board as quickly as we can. They usually change the formula a few times, and then they realize, well, maybe a little medicine will help. If you refer quickly to 485, there are your medicines. So I do want you to spend some time. I usually pull a test question from these. Basically, I would just look to know what the medicine, the most common one we use is the ranitidine. You could circle that. And then as they get older, we use Protonics. So look at one is a histamine, the ranitidine is the histamine H2 receptor antagonist, and then the other that we talked about is what? The proton pump inhibitor. Looking at the differences in consideration, we know that famotidine or Zantac basically is given within 2 hours of an antacid, and then it can cause some few side effects. Anyway, spend a little time with that. I'll try to pull questions directly from that. That was on page 485. It's called the pharmacy 24.2. All right, we can, what do we worry about with GER? What's, if they're reflux, and they can get into what? Respiratory issues, right? So besides not being able to eat because their belly hurts, get into some nutritional deficit as well. Management for GER is basically dietary or formula changing and frequent burping. And then the pediatrician will give you some orders for thickening the formula. It's a teaspoon to a tablespoon, and it's not any more than that. So we always definitely want to ask if we are adding rice cereal to thicken the formula or the breast milk, how much, and make sure. We had some people coming in, they were almost cutting the whole nipple off. They had made that formula so thick that it wouldn't come out the nipple. So, you know, there's an area for education here. We know that older kids, we can teach them to avoid things that cause reflux. And what things come to your mind? Fried food. What else? Caffeine. Spicy. Citrus. And peppermint. Famotidine, again, is one of the more common ones. I don't see cimetidine ordered much anymore. So postural changes. It says prone position is to help with that, but we don't put our babies, they stay on their back, so because of SIDS. So, but we can elevate their head, right? Yeah. Okay. Moving on down, it talks about GER interventions plus protein pump inhibitors, and it wants you to know how does it work. So if we add protein pump inhibitors, what do protein pump inhibitors versus H2 receptor antagonists do?
Reduce acid, well, protein pump inhibitors reduce the acid production, and H2 reduces inflammation.
And the other one, it says it binds an enzyme. So again, that was based straight out of your book on page 485, going back to pharmacology and bringing it forward. The surgical intervention, if it cannot be medically managed, would be what? A Nissen fundoplication, and that's a huge little surgery, big surgery. Okay. How about giving smaller, more frequent feedings? Would that help with? Yeah. We don't put our kids in car seats anymore. Used to, we would put them in a car seat after they ate for 30 minutes. We'd put them in that upright, but they found through research that it caused actually more pressure and made more reflux. So we just want to elevate their head of the bed. We want to burp them good. We don't want to put them back down until they've burped really good. Maybe just hold them for 30 minutes. Couldn't we do that in a relaxed position with the head elevated? That's what I would do. We can thicken the formula, but we need to remember it's only a teaspoon. It's not a whole bunch. A teaspoon to a tablespoon, depending on the amount of intake fluid. Burp them every 1 to 2 ounces, and that's your teaching with that child, parent, or caregiver. And again, we're going to watch that weight, because if they're not gaining weight, then we've got to do something other than what we're doing. The GERD, we're going to be giving the medication. We're going to be watching for any type of signs of pneumonia, because that's the one where they could aspirate and get into that. It says that they won't be gaining weight. That would be a problem. So that's where the medicine just solves all that. The child may cry excessively, and they can arch their neck when they're feeding. And if you've ever had a good case of reflux, then you know you're getting in all kind of crazy positions trying to live till you can get some relief. And we're going to use H2 antagonists or protein pump inhibitors. And we got to teach about dosing, right? Accurate dosing, when to give it. And that would help us a lot with that. Okay, so you have a good idea of GER and GERDs, right? All right, so now we know about 5 things, right? Intussusception. What goes on with intussusception? What is that when you look at this?
Where your intestines go back and they like fold over on themselves.
Yeah, it's like a telescope, if you've ever looked and saw how a telescope's put together. So some of the risk factors for this include a male, the Meckel diverticulum child that we talked about earlier. Appendix, CF child, cystic fibrosis, and celiac and Crohn's can all set you up for this. I imagine that hurts like heck when it's doing that. It peaks around about 4 to 10 months, it says in your book, but it's seen in a younger child and an infant. So why do I have the jelly jar sitting there? What's a visual aid that will help you? That's what color? What? Currant jelly stools, right? If you read on down here, it's a little bit further down. So when you change the diaper, that's what you're going to find. Is that normal? No. How does this child present? He presents with abdominal pain, sudden onset. It's an episodic cramping type pain, and the red flag is that they draw up their knees when they scream. They can have vomiting and diarrhea, fever, and they have a very tender, distended little abdomen. Now, sometimes it will untelescope, and then sometimes it'll retelescope. If they're lethargic, that's a late sign. So we want to be observant and assessing and try to figure out if this might be a possibility. There is a mass, and it's located in the upper right quadrant or the mid to upper abdomen. What are we going to do? They're going to use air or barium enemas, and that may reduce on its own, meaning it untelescopes and comes back normal with just a barium enema or an air enema. If it doesn't, then they have to have immediate surgery. Nursing considerations. So we're going to be assessing for dehydration, shock, or sepsis. But I want you to be alert for any type of bilious vomit, meaning it looks like bile. And that would indicate an obstruction. So I want you to add, be alert for bilious, B-I-L-O-U-S vomit, which equals obstruction. These kids will have IV fluids. They're going to be on antibiotics. They're going to have NG tube. And after reduction, maybe some clear liquids, and diet advancement is tolerated. We hope that they will pass a normal color stool, and that would mean what? That the intussusception has been resolved, and I'm sure the physician would like to know that. Okay, so got that picture? Telescope, and what does that go with? Intussusception. It kind of sounds like a telescope would look, huh? To me, in my mind. All right, appendicitis. Anybody ever had appendicitis? It comes on fast, hurts like heck. This is the perfect month for it, October and November. You'll see average age is 10, but I've seen them much younger than that. It's an inflammation of the appendix. It is right lower quadrant pain. It starts in the belly button and goes to the right lower quadrant, and as long as they got pain, you're in good shape. But when that child says it don't hurt no more, let's go home. What's the problem? It has ruptured. Very good. So remember that. They're not going to be able to walk. They're going to be all bent over, and it's going to come on fast. So I always tell them any type of I'm teaching, just good teaching, that they need to take these kids to the ED, right? Not a walk-in clinic. They need to go to the ED. What do you think they're going to do when they get to the ED? Probably a CT scan, right? Little lab work. What are they looking for on the lab if it's a true appendicitis? Elevated what? White blood cell. And what's the one that indicates inflammation? It's called C-reactive protein. Yeah, both of those. It is one of the most common surgeries that children have. And the abdomen is going to be kind of rigid. Remember where the McBurney point is? It's the point between the anterior and the superior iliac crest and the umbilicus. So that was the association of where the pain is.
How do you spell that?
McBurney point, McBurney point, Point. What do you think my vowel sounds are going to do? It might be absent, right? I got some problems going on. Fever, yep. May have a little diarrhea. I'm not going to be eating, I'll tell you. You won't be able to get nothing in me. I'm sick. Therapeutic management, what do we want to do? We want surgery, get them to the emergency room as quickly as possible, get the surgery done, and hopefully it's laparoscopic. If it's perforated, then it becomes an open appy, okay? And what do we worry about if it did infection, right? If it did burst, then they're going to probably have more days in the hospital. They may even end up having to go to ICU because they're going to have an NG tube. They're going to have a dressing. They're going to have all kind of stuff going on. They're very sick. Here is your mnemonic for appendicitis, or a picture visual. The rebound pain is at the point of the McBurney point that we talked about. So there's a rebound type of pain. See how they're guarding that area? They're all bent over. Get them help as quickly as you can. All right, let's talk about constipation. Is it common for kids to have constipation? Yeah, why? Because, and what is constipation in a kid? Do they go every day or do they go 3 times a week? Do they have a bowel movement? Everybody's individual, so you have to make sure they're intaking nutritious foods that promote a bowel movement, right? But what do kids tend in the toddler year? What do they like? JAG food. It's the same thing over and over. What do they eat? Chicken nuggets. What else? McDonald's. French fries. So I don't hear any vegetables. So you have to introduce it early. It's a one taste every meal. You have to teach it early, because if you wait till they go to school, then it's going to be another whole issue. And that's where we see a lot of kids coming in. What about their activity level? They all are less active, right? Your toddlers are probably busy, but once they go into the preschool, they get into the video games and stuff. So we have to take that away, and we have to teach them how to ride a tricycle, and then we have to teach them just to exercise, play ball. That helps. What is constipation? It says infrequent or difficult passage of a dry, hard stool. Do we quickly put these kids on laxatives? No. But again, you can detect it and prevent it by looking at the nutrition aspect and the foods that promote a bowel movement in your child. So don't let it get to the point that they have to go in and have a CAT scan to be told that, no, all it is a colon full of feces. And that can cause inflammation in the lining of the colon. It can cause all kind of trouble, and it hurts like heck. It can mimic that appendicitis pain, but it's not going to be so much on the inside as the appendix. The diet is going to be what? High fiber, and what else? fluid and more activities. Good. And if it's severe, you may get a order for what? Laxative therapy, and that's probably going to be Miralax. That's basically what we use. Or if it's a little tiny baby, it may be a little tiny Fleet's enema. Good time to talk about enemas here. There are volumes that you need to memorize. An infant could not take any more than 250 mils. With the very, very tiny newborns and young, we just use a little baby Fleet's enema, and it probably only has a few milliliters in it. So you might get to see that on your floor. Toddler would be 500, and a school age could handle 500 mils to 1,000. So your test question will probably reflect, when do you need to intervene? You have a new nurse on the floor, and she's fixing to give an infant a 500 mil soap sud enema. What do you do?
Remind them that it's only 250.
Just go to her or him and say, we're not going to give that. We're going to talk about the safety of enemas. What happens if we give too much enema fluid to a child?
Is it perforate their bowel?
Yes, and it has happened before, so that's why we share that now with y'all. All right, did we cover this? Laxative therapy, we got that, and it's not going to be forever. It's only going to be to get them through this little episode of constipation. Then we're going to go back in and reteach healthy diet. We see kids too during the toilet training times. They'll hold that stool because they're having too much fun playing, and the longer that stool sits in that colon, then the drier it gets. So we're going to promote good toilet training techniques. All right, moving right along into celiac disease. We know that it's an autoimmune disease, and it's where we cannot digest parts of wheat, rye, oats, and barley. So it's also known as it's covered with a brow diet, and you avoid what? Barley, rye, oats, and wheat, BROW. It's lifelong, and it is considered genetic. So how do we pick it up? Well, they're going to have steatorrhea. And do you know what steatorrhea is? Foul, smelling, fatty stool. We also will see they have failure to thrive. They're going to have the typical manifestations from distended abdomen, vomiting and anemia, muscle wasting. So these kids are very sick until it's diagnosed. And then once it's diagnosed, if we follow our diet, and that is mainstay of the treatment is dietary. They're going to need your fat soluble vitamins. Do you remember what they are? A, D, and one more, K. They're also going to need some folate, it says. They can have rice or corn cereal. So when they're at that age where they eat a lot of cereal, you just have to read your labels. There is a lab test, and it's called tissue transglutaminase. Or it could also be a positive IgA. And that lab test was tissue transglutaminase, TRANSGLUTAMINASE. So what kind of foods do you think these people can have? Well, we heard rice. How about potatoes? Yeah. How about cornmeal, as long as it doesn't have any of those things that are listed there.
Isn't it like gluten-free diet? Like they can have all the gluten.
It's basically just like that, a gluten-free diet. Plain vegetables, they could eat plain vegetables. They could have fruit. It says they can have milk unless it's got some type of thickening gluten in it. Just have to learn to read labels. They can have any meat except things like hot dogs, because hot dogs have something that helps them stick together called gluten. They can have butter, they can have beans, they can have eggs, they can have yogurt as long as it's gluten-free. They can have cheese as long as it doesn't have gluten in it. They could have a corn tortilla over a wheat or a flour tortilla. A corn tortilla. Okay, the next is a picture of what they look like and how it affects. These are the symptoms. So it affects a lot of different things from sight to female, male to skin to intestinal. We always just think of it more as an intestinal symptom, but look at all the things. It even can affect the joints and the muscles. What was the one thing that we learned at the beginning? Major symptom was what? Stinky stool, right? Steatorrhea. That was the first thing we studied in failure to thrive. So if it causes all these, look at all the miscellaneous things. The ones that are in red are what we see most often. So it even affects the mood swings. Vitamin deficiencies, they're going to be anemic. They're going to be low on iron, calcium, B12, and vitamin D. So that's a good takeaway on that. All right, here is another discussion on esophageal atresia. And basically, we know that atresia is where the upper and the lower part of the esophagus are disconnected. So if the upper and the lower is not connected, we got a mess, huh? What will that baby present with? Lots of bubbles, right? Lots of bubbles. And so the 3 C's, coughing, choking, and cyanosis. Frothy bubbles coming out of their mouth, excess salivation. And if you see that, your book describes it, you need to bring it to someone's attention. They also will require surgery, so we're not going to be feeding them. When you start noticing the 3 C's, they need to be put on NPO and have IV fluids. A lot of times the physician will try to pass an NG tube and it will not pass, or an OJ tube. Either one of them will not pass. That's another indicator that it's a TEF right here. The connection between the trachea and the esophagus is where there's a problem. And I just gave you a few of the pictures. You can see how it's not connected there. Okay, a hernia. We're going to talk a little bit about a hernia. And what do you think of when I say hernia?
Bulge.
A bulge. That's what I think of too. It can be in the round the belly button. It can be in the inguinal area. It can be in several different places. We just have to figure out where it is, and then sometime they resolve on their own, and then sometime I guess they would need surgery. That would be an incarcerated hernia. If it will not go back in, becomes hardened and discolored and very painful. So that would be when it would need surgery. Tell the parent, this on the next slide there. If it becomes hard, discolored, or painful, they need to notify their health care provider. All right, a little bit on the next slide. This is covered in someone else's lecture, anorexia nervosa and bulimia. With anorexia nervosa, they just refuse to maintain their weight. And with bulimia, they binge, eat, and purge. So the skid marks, scratch it out on anorexia nervosa, you don't see the skid marks from taking their fingers and running it down their throat and making them vomit after they eat. You do see it on the bulimia. Malnutrition and Kowarski, it's just a malnutrition disease, and it's a protein vitamin deficiency. And again, they kind of have a little pot belly, they're anemic. I sure can. Move this right here where it says skid marks. Scratch it out and move it down to bulimia. That's all I need there. And with anorexia, one of the first things, besides looking at them, why? Because they tend to be kind of wasted and they will not eat. The female starts missing periods. Their hair is very dull and they have dental caries. with the bulimia nervosa from that constant making yourself vomit foods, you're going to have dental caries as well as that. All right, I've put you in some notes. Did I give you this? You have this. We've kind of already learned that with our other case that we studied. Okay, we're going to do something fun then the rest of the time. So let's go see if I can pull up some fun stuff. We're going to go here. All right, let's see how we do. This was your pre-quiz. I can't speak it enough. Lippincott has such wonderful opportunities for learning as well as prep you. A lot of times before you start your study, that will help you get focused. So what do y'all want here? I'm going to start with Alexandria. Can you answer that? Okay, I can't see it. Infants with gastro reflux should be put in a car seat after they eat. True or false? And no, and I explained that when I was lecturing. Many years ago we did, but we don't do that now. That's why we have good research going on in your research class, right? We want to always be the best. This goes to Alexandria again. Which factor increases the risk of pyloric stenosis? What? Okay, do you want maternal smoking, exposure to antivirals, breastfeeding, or being born post-term?
Blame that on everything. Maternal smoking.
Because she was smart.
What you want, you want post-term or you want maternal smoking? What puts them? I don't think it's in our notes. It must be in the book. You want to go with smoking because that's bad, huh? What y'all want in Shreveport?
Smoking.
All right, so we are going to go with smoking, and when we don't know the answer, we're going to go with things that are not safe in this case, right? You always pick the safest answer to answer a question. So this might put you at risk. All right, going to Shreveport now. Which assessment finding would indicate a development of appendicitis in a school-age child?
The first one. Oh, you're right.
Okay, is that what y'all want, Alexandria? Yay, nay, okay, all the above. Failure to pass plutonium in the first 48 requires further investigation for Hirschsprung. Y'all want on that?
There. That one's the one with this.
Your browser, we're having trouble seeing in Shreveport.
Y'all want what?
Can you expand your browser with the quiz in it? We're having trouble seeing.
Okay.
Full screen. Oh my. Can you zoom in?
Can you make it bigger?
It is.
I got it pretty big. I don't believe I can. Y'all want true on this? Let's go with true. That was one of the first things we noticed, I think, in our notes. An important nursing intervention to help reduce aspiration is to place an infant slightly elevated after feedings for 30 minutes. That goes to Alexandria. You want true or false? True. Okay. Shreveport, you like that? True.
Yeah.
Okay, good job. This goes to Shreveport. What complication commonly occurs in children that is diagnosed with cleft lip and cleft palate?
Medium.
All right. Going back to Alexandria for the next one. When planning meals, a kid has celiac. The nurse would avoid giving which of these foods? Celiac. All right.
Yeah, let this be.
Going back to Shreveport, the most common birth defect of the digestive system is what?
Meat kills the reticulum
Wait. You know, Markle. Or Medical.
I cannot see that. It's like, do I have glasses for no reason?
Yeah.
I can't see nothing.
In ulcerative colitis, both the large and small intestines are involved, or areas of normal bowel are skipped. In ulcerative colitis, we didn't really talk much about that.
True.
Y'all want true?
False.
All right, let's go with false, okay? And children with peptic ulcer disease should avoid using Tylenol for pain because it irritates the gastric mucosa.
False.
That's going to be false. We know if it would say Motrin, it would be true, right?
Right.
All right, I believe, let's see, what y'all think we made? A, B, C. I think we made an A. Ooh, we did better than A. Okay, so you definitely were listening and you definitely learned. So that's a good thing. Let's see if we can do one more thing if I can find it down here. Okay, you got a Nearpod game. Let's see if I can find my Nearpod.
Wait, do I need to sign?
Go ahead and sign into Nearpod. Or log in and that's your code.
Oh, how fun. Read.
Your part, which character?
I can see it.
Wait, sign up request. Wait, join in the list.
Y'all need the code. The number was 35SFQ. 35SFQ. Everybody getting there?
Here. SF.
It's 35SFQ. 35SFQ.
I'm gonna get it off. I like the octopus. I didn't see that one. I like a purple bird.
I don't see an octopus. Oh, I do. Lisa's an octopus.
I'm interested.
No.
Panda too. It gave her panda power.
Nobody wants to be an octopus with me?
Nobody wants the octopus.
Only one that did the other one.
You are the unicorn.
Who's the green turtles?
I like that. And then there, what is that, like an alpaca? Yes. You do.
I think they're alone.
The other thing that's good is the 1-minute videos. There's one called Acute GI Disorder, and it's really good too. Y'all would do well on it if we had time. All right, was everybody present? Anybody not in that needs to be in? Everybody in here is in? 340, y'all in?
Yes.
Okay. Good job. We did a little unfolding, we did a review of our chapter, and we filled in the blanks. So everybody should have got that. My client has Hirschsprung. You come in with fever, explosive diarrhea. What do you do first? first one was the ribbon stool. Do you remember that? AKA mega stool, mega colon. Gotta get a healthcare provider on board. That's not gonna be an easy fix. Okay, this guy's got pyloric stenosis. What was the characteristic takeaway we talked about? Project. Sorry.
I don't know. Yes, I
Working on
know.
my mouth. There you go, Ben. All right, good job. This is active thinking, bringing back what you were learning today. 11-year-old with celiac. They need to avoid what? Good job. Left hip.
Oh, I'm probably got that one.
Oh,
Oh, I dig it. Okay.
I was about to say, don't say that.
Yeah.
Damn, the whole thing.
No. I don't know. Yeah.
He said I just heard about it. I just selected that and I feel like, I don't know.
You decided it too quickly.
Oh.
So if we have a child that failed to pass meconium in the first 24 to 48 hours, what diagnosis might you see?
Correct answer.
So everybody got it wrong.
Yeah.
Oh, sorry.
Yeah,
That's how you right. Right. Nah.
But the only one is on the free call. No way.
How will you evaluate the effectiveness of the treatment of thickening of formula for a child that has reflux?
That's what she said.
Yeah.
You got to put 1 teaspoon.
Is it
One head.
Wait for the vomiting.
Well, and vomiting. Oh, and it's
What
vomiting.
was the vomiting? Evaluate it. That would say that's
I didn't read it.
Emily and Emily.
Oh, I read that question wrong.
Job.
Put it. I thought
Oh,
you
shoot, I
were here, but I. Oh,
Inappropriate.
well. I placed it too.
Heard that wrong.
Totally.
But it's.
I put it there.
Their mucus membrane. Good job. The others you would expect.
I put it too fast, so I read the question.
What position?
And then, oh, I think that's wrong too.
No, it's not in.
It's supposed to be sitting right up, but
I thought it was upright.
it is upright, cause prone is on the stomach, supine is on the back, on the, on
I
his
think
side.
it's fine.
You can't feed him on his back, cause he's gonna get an ear infection.
Side.
You want
Yeah.
upright, you didn't find upright, but you found on it. Aspirates for minutes. That was one of our first questions, I think, on our PowerPoint.
But I feel like that.
On the side. That's weird.
She said, oh,
She did say it right.
That's only because I read that question slow. I'm not much anymore. Pretty good vibration. Oh, no, it's been a little tricky.
how does he read it? Yeah.
This goes to Malik in chapter 5. He's a Muslim religion. So it goes back to level 1, I believe.
Yeah, Chris.
Always ask when you have a mission from a different culture or a different religion, ask about dietary or practices. We have to honor them while they're in the house.
Yeah, he's right.
Virus lab for a child that has rotavirus.
We never did no stool closure or nothing. Right? They do it as well.
Priority is one of those key words when you see this question. All your options might be correct, but they want you to pick the best. I'm gonna pick the umbrella.
Yeah.
You gotta diagnose it first. Huh?
Let's hope it's their lows.
You gotta kill them quicker. Sodium, potassium imbalance, kill them quicker than anything, yeah.
It's to the
A lot of
numbers.
times you have to apply what you know from med-surg and figure out the answer. This is a strata question.
I'll take
With
intricate.
rotavirus,
Right here? Oh.
this goes back, pulling back to basic care and comfort, your basic knowledge.
Yeah, no, it's tricky. And here I can find mine. I remember the empirical. Okay. I know, it's so sad.
You know, they gave us their name names. It's podcast.
We have Emily in the lead,
Maybe
Emma
that's
and
him.
Lisa. What was the initial diagnosis? If you attended the labs with Harper in the first part of our study today. We were really doing a good CJC, and y'all came on strong on that. Good job. We have looking up something before you come to class. It's just like second, you get a second application and it's fixed. You don't have to study that anymore. Last question.
That's
When they get sicker, what do we need to be doing?
Oh, it's on there.
Change the status of my health
She doesn't seem like she was something.
Come out of here. Where they can have one-on-one and closer watch. Okay, today's winners were Emily, Emma, and Lisa. Caleb, Lauren, Chloe, Diane, Haley, Carson, and Madeline. All good job. Okay, before we close off today, I'm gonna encourage you to go to page 501. Go to page 501 in your book real quick. All right, what's at the end of every chapter? And do we pull test questions from it? Yes, we do. Do we encourage you to, if you do nothing in prep for your next lecture, go straight to those questions? And it's amazing what you will, if you answer those before you come to class, you will do much better in lecture. Let's look at 2. 2's a good one for a little bit of talking. The nurse is creating a discharge plan for an 11-month-old who has gastroenteritis, same thing that Harper had. What signs and symptoms should prompt the caregiver to call the physician's office? What were some of the things that she had that they called in on? Fever, you remember that? That she stopped feeding, and that's the number one reason, and no wet diapers. That's what brings them into the emergency room. So as you're doing your well baby teaching in any situation you can, you share that with them. About 8 to 12 hours is the most. They need to be in an emergency room when that child has not. That means they're getting from moderate dehydration to severe. And what is so good about getting them in a little earlier? You can get an IV on them, right? If they're not severely dehydrated, you can actually get an IV, right? All right, I was just looking to make sure we covered all the others. I think we did. Do I have any questions on chapter 24 today? Okay, and are there any questions in Shreveport? Thank you for participating. Thank you for doing your ticket to class, and I think you'll do fine. You should be well prepared. Very, very little studying because you came a little bit more prepared. Try to do that every class and you'll get way more out of this. Today I would go straight to my prep youth on GI. I think you're ready for it. Okay. Alexandra, do you have any questions for me? None? Okay, I'm going to end this lecture. It is 11:50. Y'all have 10 minutes to spare. Thank you.
Thank you.
Have a good day. There is a celiac disease YouTube. I have linked it and you can watch it at home. She does a good job on celiac.
Yeah, and then when she says she don't repeat, she keeps on.
Now I need to figure out how this recording.
Because now, like, I ain't gonna lie to this weekend. I need a mental break. I'm sure that, I mean, you're gonna go on the pot, and I was on it, they're that were not graded. Yes, I know.